To present this topic, my team consists of four distinguished esteemed speakers. I would like to start the topic with the first speaker, would be Dr. Nabila T, Assistant Professor of KMCT Medical College, who will be presenting the topic Preserving the Curtains of Eye, that is, the principles of lid repair.
Okay, so a very good evening to one and all. At the outset, I would like to thank KSOS for giving me this opportunity. So, as we all know, ocular trauma is one of the major etiologies for monoocular visual impairment. And tragic headlines like these are very often seen on our waking up mornings, right? And sights like these are not unusual on our day to day travel. And not only road traffic accidents, we have other causes for ocular trauma as occupational injuries, sport injuries, and assaults. And in case of children, we have animal bites and cradle hook injuries as more common causes. So, among the cause of ocular emergencies, trauma accounts for about 33%, and among them, lid lacerations are seen in around 40% of the cases. So, today I will be talking about preserving curtains of eye, principles of lid tear repair. So, before going for a lid tear management, you must be knowing about the anatomy of the eyelid very well. Okay, so just brushing through, you have the outermost skin, then the underlying orbicularis constituting the anterior lamella, then coming the tarsal plate and the conjunctiva constituting the posterior lamella. So the peculiarity of the eyelid skin is that there is no subcutaneous fat and it is the thinnest layer of the body skin. And the orbicularis, it is made up of an orbital part and a palpebral part. And then we have the tarsal plate, which is responsible for the structural integrity of the eyelids, and it is attached on either side of the periosteum by the medial and the lateral canthal tendons. Then we have the levator palpebrae superioris muscle and aponeurosis, which is attaching onto the anterior surface of the tarsal plate. And beneath it, you have the Muller's muscle, which is attaching on the superior border of the tarsal plate. And then we have the orbital septum, which has an attachment from the superior orbital rim over to the levator aponeurosis. And behind it, we have the pre-aponeurotic pad of fat. Similarly, within the lower lid, from the facial sheath of the inferior rectus muscle arises the capsulopalpebral fascia and the inferior tarsal muscle, which acts as a lower lid retractors. And between the orbicularis and the levator complex, you have an avascular plane which is extending onto the eyelid margin as the gray line, which is a very important surgical landmark. So, on evaluation of a lid injury, take a thorough history because mechanism of injury can give a clue to the depth of the wound, and assure the basic airway, breathing and circulation of the patient. Rule out underlying globe injury and get an adequate documentation, preferably a photographic. So the goals of lid tear repair includes eyeball protection, restoring anatomic and physiologic function, and cosmesis. Okay. Now coming to the general principles of lid tear repair. So initially have a thorough exploration of the wound. Okay, so get an extent and depth of the wound. Decontaminate the wound as far as possible. Just flush it with saline and remove all possible foreign bodies. So because of the extreme good vascularity of the eyelid skin, debride only clearly devitalized tissue. And the reconstruction should be done in layers to get a good apposition. And always remember, primary repair gives the best result. So eyelid injuries can be either extramarginal, eyelid margin involving, eyelid laceration with canalicular involvement, or eyelid injuries with tissue loss. So coming to extramarginal, it can be either superficial or deep. Superficial lacerations like this, you just have to oppose it with a non-absorbable suture, a 40 silk or Proli. Just you have to remember that when suturing the skin, the needle should be entered at a slightly outward angle so that it will result in a slight eversion of skin edges so that when the wound heals, it will prevent it from inversion. So coming to deep laceration, you have to gently explore to measure its depth, rule out underlying injury to the eye, orbit or cranial cavity. So wounds which may appear as superficial outside may have an underlying extensive injury like this, in this case a globe rupture. So a deep wound again extending up to the orbital rim. So when you have a deep laceration, suture it in layers, muscle with a 5-0 vicryl and skin with a silk or proli. So this is a case of a deep wound sutured in layers to give a good apposition like this. So if not done, it may result in a bad wound like this, where you can see tissues protruding in between. So this was a wound which came, it was opened up, resutured in layers to give a very good apposition like this. So now you can have wounds like this where you have an orbital fat prolapse. So once you get wounds like this, one thing you have to remember is that at least the orbital septum has been breached. Okay, so in these cases, the fat must be cleaned and reposited gently, and the orbital septum is not sutured because it may result in a lid retraction and lag of thalamus. And if you have an underlying levator injury, it must be sutured over to the anterior surface of the tarsal plate, or else it may result in a ptosis. This is another, so this is a case of an 8-year-old girl with a cradle hook injury. You can see fat prolapse. Luckily, there was no underlying levator injury. It was cleaned and reposited back, wound sutured in layers to give a good postoperative outcome. Now, in cases like this, here it is a 28-year-old male with an occupational site injury. You can see a steel wire piercing the eyelid. So ideally, you have to go for an imaging to know the depth of penetration of the foreign body. So here, in this case, it was a steel wire with a double entry through the eyelid, and luckily it was only superficially touching the sclera with a partial thickness wound. So this just the wound either side of the steel wire was extended, foreign body removed, sutured and left. So coming to eyelid margin involving lacerations, initially you have to identify the gray line, pass the first suture through the gray line, preferably a vertical mattress suture using a 6-0 or 5-0 silk. And then pass sutures anterior and posterior to the gray line. Certain surgeons prefer only 2 sutures. And these sutures are left long. Okay, then you suture the tarsus, which should be a partial thickness suture. This suture must at least pass 2/3 thickness, but not full thickness, otherwise it will rub the cornea. Then you have to suture the skin and orbicularis, and the marginal sutures are left long, and these are tucked under the skin sutures. One thing you have to notice, after suturing, the sutured wound must result in a lid pout. Only then the plane of scar will come in line with the eyelid margin. So a good apposition with slight margin eversion should be the goal. So again a case, a 9-year-old boy with a cradle hook injury, wound sutured in layers with a postoperative 1 week. Now, when you have a canalicular involvement, when do you suspect these? When you have lacerations medial to the punctum, or when you have a lateral punctal displacement, or in case of bite injury. So whenever you suspect, probe to rule out canalicular injuries. And canalicular injuries mandates primary repair, otherwise it will result in lifelong epiphora. And identifying the proximal end of lacerated canaliculus is a difficult task at times. So what are the methods? You can examine under good illumination and high magnification to see a white circular puffed out edge. Okay, or you can irrigate fluid or air through the uninjured canaliculus and see where the jet of water is coming through. Or you can pool normal saline in the medial canthal area and inject air through the intact canaliculus. Or fluorescent dyed normal saline or viscoelastic is injected through the intact canaliculus. So whenever you do a canalicular injury repair, always possible, usually a stent. Okay, so the stents it can be used are a mini monoca stent, which is usually a monocanalicular stent, or a Crawford bicanalicular stent, or even an angiocath IV cannula can be used. So whenever we are going for a lid canalicular repair, initially do a punctal dilatation and probe through the proximal end to confirm whether it is going to the sac. So just to show a video. So this is a stent. You can cut the end to make it a beveled edge for the easy entry. So this is passed through the distal cut end and just pull it so that it gets plugged within the punctum, and the coloretta is staying in flush with the eyelid margin. Okay, then the distal end is passed through the proximal, earlier identified proximal cut end. Okay, then you have to suture just anterior and just posterior in the pericanalicular area, resulting in a pericanalicular anastomosis, and the rest of the layers are sutured. So this was the case, a 28-year-old male with a history of fall from bike. The repair was done using a mini Monoca stent, and the external layers were repaired in layers. So this is a post-operative 1 week. Okay, now when we don't have stents in hand, can we use any other materials? Yes. So this was a case which is an upper lid full thickness injury and a lower canalicular injury, and here it was cannulated using a number 1 proline suture. Okay, so this was a post-operative picture. You can even use our usual IV cannulas, 24 gauge and 22 gauge, where the Teflon sleeve is used as a canalicular stent. Just that you have to secure the tube to the skin by the sutures. But the extrusion rate is high and patients may get inflammation. Another thing to remember is that canaliculus is closely related to the medial canthal tendon. So you may have medial canthal tendon injury associated with a canalicular injury. Okay, so here this is the anterior crus of the medial canthal tendon. Just behind that you have the lacrimal sac and the canaliculus, and behind that the posterior crus. So if at all there is a medial canthal tendon injury and you haven't repaired it, you may get a residual defect like this. Okay, so make sure that the medial canthal tendon is not injured, and if at all it is injured, at least make an effort to attach the posterior crust to the posterior lacrimal crust, because that is the one which gives the integrity of the medial canthal tendon. So when you have tissue loss, for small defects you can do a direct closure or a lateral canthotomy with a cantholysis. For moderate defects you can go with a tensile semicircular flap, and for large defects you can go with flaps like mustard cheek rotation, Hughes tarsoconjunctival, or a cutlet beard flap. So just finishing off with an interesting case, we had a 48-year-old male who presented with a small lid abscess in the right eye for 2 days duration. An incision and drainage was done. He had a history of road traffic accident 2 weeks back, during which he had sustained an injury to forehead and it was sutured, but he had no history of injury to lid at that time. He came with a recurrence of the swelling 1 week later. A repeat incision and drainage was done, and we could find a tract which is going upwards from the site of the lid abscess. The wound was extended and explored, to our surprise to see a foreign body coming out through the wound. So it was a button on the raincoat which he was wearing during the accident, which was accidentally incorporated within the wound, and which would have tracked through the subaponeurotic plane downwards to the lid between the tarsus and the orbicularis. So finishing off with a take-home message, always rule out a globe injury before proceeding for a lid repair. Primary repair is the best repair. Repair all canalicular lacerations whenever possible, and minimal tissue sacrificed in avulsed injuries is the rule because of the excellent vascularity of the lid. So an early, meticulous, primary restoration of anatomy is the key to success for a lid repair. Thank you.
Thank you, Dr. Devila, for this very informative talk. My next speaker would be Dr. Jyoti, who needs no introduction, who was the HOD of Calicut Medical College and now is the HOD of KMCT Medical College. Madam will be presenting the topic mending the coats of the eye, that is the techniques of corneoscleral wound suturing.
A very good evening to all, and thank you, Shamsir, for the kind words of introduction. I'll be talking about the techniques of corneoscleral wound suturing. Corneoscleral tears are one of the leading causes of ocular morbidity and require prompt and proper management. In the initial evaluation, after a detailed history and thorough systemic and ocular examination, it is always important to rule out the presence of an intraocular foreign body. Surgical repair of the corneoscleral wounds should be done very meticulously. You have to start broad spectrum antibiotics and tetanus prophylaxis at the primary contact level, and preferable to do the primary repair within the first 12 hours. Corneal lacerations can be partial thickness or full thickness. And if it is a partial thickness corneal laceration, if the wound edges are in good apposition, you can give pressure patching and prophylactic antibiotics. Partial thickness unstable wound, you can use a bandage soft contact lens to support the wound. Partial thickness corneal lacerations can be there with flaps. If the flap is very well apposed, you can use bandage soft contact lens. If it is a displaced flap, reposition and secure with sutures. Full thickness self-seal corneal lacerations, if it is less than 2 mm, conservative management with prophylactic antibiotics and bandage contact lens can be used. For larger self-seal laceration, routine surgical repair, or you can use cyanoacrylate glue. So what are the indications for suturing in corneal lacerations? If it is a large laceration, if the wound is displaced, if wounds with tissue loss or tissue incarceration, and in children it is always better to suture. So what are the problems that we come across in corneal laceration repair? The lack of elasticity of the corneal tissues, which will not stretch or replicate. The goals of surgical repair are to achieve watertight globe and maintain the structural integrity, prevention of complications like glaucoma and infection, and the final goal should be to be an optically clear, smooth curvature of the cornea and good visual outcome. So when you see a corneal tear, assess the length of the tear, depth of the tear, morphology of the tear, presence of limbal involvement, extent of corneal edema, and presence of tissue loss. So there are certain landmarks which you have to identify for proper alignment. One is the limbus, epithelial pigment lines, stellate edges, and sharp angles of laceration. So if you can identify these and apply the first suture at these lines, you can get better alignment. And corneal suturing is done with 10-0 nylon suture on a spatulated needle, which causes little tissue reaction, and the tissue margin should oppose as precisely as possible. Simple interrupted sutures are preferred, and the ideal depth of the suture should be 90% of the corneal tissue, and the length should be 1.5 to 2 mm and of equal depth on each side of the wound. So the sutures typically have semicircular needles which create a circular path. And to pass the suture with a semicircular needle, the movement is like turning a screwdriver in a circular motion. Excessive pushing in a linear manner will cause the needle to bend and the tissues to distort. Symmetrical suture, you can see the middle one is symmetrical. It has got a very good holding power, whereas asymmetrical sutures does not provide the same security. And similarly, the entry angle of the needle should be perpendicular to the wound. Right angles result in normal depth, whereas if it is an acute angle, it results in shallow depth, and if it is an obtuse angle, it can result in excessively deep suture passes. Another important thing is the holding power. The holding power is strongest under the suture, and it decreases further away, distributing the forces in a diamond shape. So here you can see short sutures distribute the force over a smaller area. Therefore, you require more sutures to close the incision. Whereas the ideal balance, the middle one, you can see the ideal balance of suture length and spacing, where the forces provide good holding power for the entire incision. Longer sutures distribute the forces over a larger area and therefore give less effective holding power for the incision. Another important aspect is the zone of tissue compression, roughly equal to the length of the suture. To avoid the wound leakage, the zone of tissue compression caused by adjacent sutures should be in contact or overlap slightly. Then ideal suturing, when deep suture placement should be equidistant from the wound margins, which gives excellent wound approximation, except in oblique or shelving wound. So what happens when you put shallow sutures? It creates an internal wound gape. When you put full thickness sutures, it may create a conduit for microbial invasion. That is why it is said about 90% corneal thickness. Sutures of unequal depth, shallow on one side and deeper on the other side, can cause wound override. Similarly, sutures of unequal length also can cause wound override. So full thickness corneal laceration can be perpendicular or shelved, which requires slightly different approaches to suturing to facilitate correct wound edge apposition without overriding or distortion. Vertical or perpendicular laceration, the suture entry and exit site should be equidistant from the wound margins so that the corneal suture is centered over the wound. Whereas for a beveled or a shelved laceration, you can see that it should be centered on the posterior aspect of the wound margin rather than the anterior aspect. If you center it at the anterior aspect, it can produce a posterior wound gape. Tying of sutures, suture nodes should be tied with either 311 or 211 throws. And after that, knot should be trimmed short and rotated back just beneath the corneal surface, and it should be buried under the corneal surface. So ideally, when you suture, it should be like this with the optimum strength, length, as well as the zone of tissue compression should be ideal. And you can use the no-touch technique. If the anterior chamber is well formed and the wound is watertight, the sutures may be placed directly without entering the anterior chamber with instrumentation. Whereas in less stable wound, you can reform the anterior chamber with balanced salt solution, air, or viscoelastic. A limbal paracentesis is preferred rather than disrupting the wound edges, and which can permit better access. So when the wound edges are edematous or macerated, you can put slightly longer sutures to incorporate healthy tissues. Equal amount of tissue should be incorporated on each side of the wound, and full thickness suturing provides good tissue approximation in such cases. And wound slippage can occur in non-perpendicular sutures. The sutures should always be placed at right angles to the wound edge to avoid wound slippage. When the laceration is affecting the visual axis, either you should avoid the central cornea by placing them on either side but not through the axis, or by making the suture bites close to the visual axis shorter. So this is the Rose-Hayes technique of corneal suturing, where you put longer, closer and slightly tighter sutures in the periphery and shorter, wider and loose sutures in the center, which will neutralize the surgically induced astigmatism. Stellate laceration is another challenge. It is difficult to obtain good apposition and watertight closure. Several techniques may be used: multiple interrupted sutures, or bridging sutures, or purse string sutures, and star-shaped sutures. If closing a stellate laceration is difficult and leaking persists, you can use a tissue adhesive or a corneal patch graft. This is the continuous star-shaped suture to suture a stellate wound. When there is corneal laceration with uveal prolapse, tissue that has been prolapsed for longer than 24 hours should be excised to avoid infection. But if it appears healthy, it may be replaced with caution. But macerated, feathery or devitalized or depigmented iris should be excised. So some general guidelines while repairing the corneal wounds: handling of the tissue should be kept to minimum. Avoid repeated attempts at grasping the wound edges, which can lead to maceration, especially if the tissue is edematous and fragile. The needle point of the 10-0 suture should be prevented from touching any other tissue other than the wound edge. And maintain the anterior chamber with a tight air bubble, which helps to do the suturing without grasping the wound edges with forceps. Avoid putting sutures in the visual axis, as I have already discussed. Now comes the scleral wounds. Scleral wounds can be missed, especially in ruptures, because it is covered by the intact conjunctiva or a subconjunctival hematoma. You should have a high index of suspicion in cases with typical history and clinical signs. Exploration should be done in all doubtful cases, and special attention should be given to areas of insertion of muscles where ruptures can occur and areas in between. So what is the general principles of scleral suturing? Full thickness scleral wounds are generally apposed with 80 silk or nylon with a spatulated needle, and ensure proper exposure and visibility of the wound edges. The common mistake that we come across is involvement of the tenons or conjunctiva in the suture supposed to approximate the sclera without incorporating the sclera. I have seen one case where one bite was taken from the scleral edge and the other bite was approximated to the tenons on the other side, and the patient developed a staphyloma like bulging, and the wound was re-explored, and it was found that the one edge was sutured to the tenons instead of sclera. So always clear the tenons and conjunctiva completely off the wound edges before passing the suture, and reposit any prolapsed tissue, excise vitreous at the wound. And scleral wounds are generally closed from anterior to posterior. Begin suturing from a recognizable landmark. First suture at the limbus if it is involved, and for larger wound extending from the limbus, you can use the close as you go strategy and expose the conjunctiva and see whether there is a scleral wound which is extending, and suture accordingly. And leave the last tight suture ends long so that it can be used to exert traction to rotate it anteriorly to expose the posterior portion. And posterior to the equator, it can be left unsutured. Scleral wounds under the muscle, you have to retract the muscle or even disinsert the muscle to allow suturing. So for corneoscleral wounds, you can combine the principles of both corneal and scleral repair. Landmark here is the limbus. Next, suture the corneal aspect of and then the scleral. So in a wound like this, first suture the limbus, then the corneal aspect, and finally the scleral aspect. And to conclude, placing a suture with good depth, symmetry, spacing, and length with the correct tensile forces is an art and an integral part of ophthalmic surgical technique. Both a science and an art to get a good sutured globe. Thank you. Thank you for your time.
Thank you, ma'am, for this wonderful talk. The next speaker I would like to introduce is Dr. Neetu Krishnan, who is also an assistant lecturer in KMCT Medical College, will be presenting the topic, the blood eye. That means the management of traumatic hyphema.
Very good evening to all. So let us start with the bloody eye, management pulse of traumatic hyphema. Okay, my presentations include what is hyphema, grades, complication and management. So first of all about the hyphema, what is hyphema? Blood in the anterior chamber. The causes include blunt injury, open globe injury, and source of bleeding can be occur from the peripheral iris, sphincter and anterior ciliary body. The spontaneous hemorrhages can occur in cases of neovascularization of iris, vascular hematomas of iris, herpetic eye disease, retinoblastoma, sulcus IOL, coagulation disorders, leukemia. After intraocular surgery, the bleeding can occur from the granulation tissue and damaged uveal tissue. These are the spontaneous hemorrhages. Our topic is blunt trauma. So let us start with blunt trauma. Okay. In case of blunt trauma, there is first of all there is an anterior posterior compression, following which there is an equatorial expansion, which induces stress on the angle structures, resulting in rupture of iris stromal vessels and ciliary blood vessels, which resulting in hyphema. Okay. In case of lacerating injury, there is direct damage to the blood vessels, which resulting in hyphema, and along with the hypertony itself can result in rebleed and hemorrhages. The secondary hemorrhage or rebleed is occurred due to the clot lysis and retraction from the traumatized vessel, usually occur 2 to 5 days after the initial injury. So with the history and examination, the case of trauma, we have to ask about how to trauma is occur, any possibility of intraocular foreign body, and along with the history like defective vision. In case of hyphema, patient may complaining of eye pain, nausea, photophobia, and vomiting. Along with, we have to ask the chances of coagulative disorders like sickle cell traits, because the complications and managements are different for these sickle cell traits. I will explain next slide. Okay. And there is need complete ocular examination, include intraocular pressure and dilated fundus examination is very important. And we also need to rule out the chances of ruptured globe, because along with the hyphema and subcongenital hemorrhage, there is chance to miss out the ruptured globe. So in case of occult rupture, there can be signs like low IOP, poor vision, deep anterior chamber, pupillary distortion. We have to rule out the occult rupture. Next, about the classification of hyphema, the grade 0 microscopic hyphema, which include only the RBCs, no layered hyphema, but RBCs itself can result in raised IOP and complications. Next, the grade hyphema, which include 1, 2, 3, grade 1, 2, 3, 4. The grade 1 is level of the hyphema less than the 1/3 of the anterior chamber. Grade 2 is 1/3 to half of the anterior chamber. Grade 3 is up to the less than the total hyphema. When the grades are increasing, the severity of hyphema and complications are increasing. So, in case of grade 4, there is total hyphema. It's also known as 8-ball hyphema because it just appear like in a black or dull red appearance, like an 8-pool ball. It occurred due to the hypoxia and impaired aqueous circulation. The most complication that relate to grade 4 is the pupillary block and secondary angle closure glaucoma. Next, about the complications, the first of all about the raised IOP. The development and severity of glaucoma depend upon the amount and severity of hyphema. The other secondary glaucoma that related to hyphema or trauma is the angle recess glaucoma, ghost cell glaucoma, and hemocytic glaucoma and hemolytic glaucoma. The other complication that related to hyphema is the recurrent bleed and optic neuropathy, permanent visual loss, and corneal blood staining. I will explain. First of all, about the few words about the rebleed. Rebleed can occur in relation to hypotony. Hypotony itself can increase the chances of rebleed, and the rebleed usually occur after 3 to 7 days and due to the clot lysis and retraction from the traumatized vessel. And in case of rebleed, 50% cases can relate to secondary glaucoma and refractory glaucoma. In case of trauma or ifema, we have to delay the gonioscopic examination to prevent the rebleed, usually done after 1 month. Another important complication is the corneal blood staining. The triad of hyphema, glaucoma and endothelial damage increase the chance of corneal blood staining. In the IOP of 25 mm mercury, raised IOP more than 6 days can resulting in corneal blood staining. The pathology, the main pathology is in hyphema, the RBCs in the anterior chamber break down to hemoglobin. This penetrates the posterior stroma, and where it is hemoglobin break into hemosiderin, give an yellow granular appearance. So it usually clear very slowly from the periphery, may occur as a permanent. In case of pediatric age group, one important complication that related to corneal blood staining is amblyopia, may be needed keratoplasty. And corneal blood staining can also mimic like a clear lens dislocation. And in case of hyphema, follow-up period, we have to assess the vision, hyphema status, intraocular pressure, corneal blood staining in every day for initial 4 days. After 1 month, we have to do the gonioscopic examination to rule out the angular recession, and retinal fundus examination also need to assess the retinal pathology. So let us start with the investigation. The routine blood investigation, along with the routine blood investigation, we can do anterior segment OCT. Anterior segment OCT is a non-contact procedure, so decrease the risk of rebleed. We can assess the anterior chamber depth, occult intraocular foreign body and lens wall. And another one is the ultrasound biomicroscopy, which is given a good ciliary body visualization. So we can rule out the cyclodialysis, angular recess and iridodialysis and occult foreign body. Another one is the ultrasonography. In case of hyphema, there is hazy media, so fundus examination is very difficult. So with the ultrasonography, we can rule out the retinal detachment, intraocular foreign body, lens dislocation and occult scleral perforation. So in our topic management, so start with management. We have to know the complication we already studied. So what are the complications? Raised IOP, glaucomatous optic atrophy, corneal blood staining and secondary hemorrhage. So our management is prevent these complications. So initially we have to advise patient to bed rest and head elevation to settle down the hyphema or to decrease the chances of rebleed. And there is inflammation. We have to treat inflammation first. We can start with the topical corticosteroids, which act as an anti-inflammatory along with it to prevent the rebleed. And cycloplegic can give relieve the ciliary spasm and also decrease the iris movement. So another agent we can give the antifibrinolytic agents, which given prevent some amount of chances of rebleed, but no significant effect on visual outcome. It has its own systemic side effects. Next, our important part is to prevent the glaucoma or anti-glaucoma medication. We can give topical beta-adrenergic blockers, and topical adrenergic agonists can be given, especially in case of young children. But in case of sickle cell, it should be given in caution because it has an alpha-1 action also can result in vasoconstriction. So in sickle disease, already systemically compromised circulation, along with the vasoconstriction, it increases the chance of optic damage. So in sickle cell trait, topical adrenergics are given in caution. Okay. And topical and oral carbohydrates can given, but in case of sickle cell traits, which increase the anterior chamber acidosis, so resulting in more sickling and complications are more in case of sickle cell. So we have to use it in caution. In all cases, prostaglandin analogs and pilocarpines are contraindicated because prostaglandin analogs increase the inflammation. Pilocarpines can result in peripheral anterior synechitis. So these are contraindicated in case of hyphema. Next important is corneal complication is the corneal blood staining. So to prevent corneal blood staining, we need surgical interventions. One of the indication for surgical intervention is the corneal blood staining. Clot should be evacuated. And along with that, we can control the IOP. In pediatric age group, one of the complication is amblyopia. So we can do keratoplasty. Next about the surgical intervention. Indications include uncontrolled glaucoma. First one is the uncontrolled glaucoma. Intraocular pressure more than 25 millimeter of mercury for 5 days with the total hyphema is one of the indication, and more than 35 millimeter mercury for 7 days, and intraocular pressure more than 60 for 2 days to also indication for the surgical intervention. Any hyphema resolving less than 50% within 8 days also another indication, and total hyphema is more than 6 days is also can result in severe optic nerve damage. So we need to surgical intervention. Another important point is I already explained, and the corneal blood staining is the one of the indication for the surgical interventions. And if the patient having glaucomatous optic neuropathy in fellow eye, we need surgical intervention. The surgical procedures are include are the paracentesis or release of blood through the limbal incision, and also irrigation and aspiration with the Simcoe's cannula or with bimanual irrigation aspiration probes. In case of organized hyphema, we are using anterior vitrector or Uthrata forceps. So a few words of sickle cell traits. Even small grades, even a low level of hyphema can result in severe intraocular pressure rise in sickle cell traits. So we can give anti-glaucoma medications, but and beta blockers are safe. Topical carbonyhydrates and alpha agonists are used in caution, and along with we can give transcorneal oxygen therapy. Thank you.
Thank you, Dr. Nito, for this informative talk. The next, last but not the least, our next speaker is Dr. Prakash, who needs no introduction. He is one of the leading retina surgeons and administrative of Contrast Eye Hospital, Calicut. So we'll be presenting Look Out for the Hidden Surprises, that is, the management of intraocular foreign bodies.
Thank you, Dr. Shamsher, and good evening to all. So, intraocular foreign bodies constitute 40% of open globe injuries, and majority happens at workplace. In our hospital, we see mostly from the most common cause is grinding. Tiles grinding is the most common. Next is grass cutting, followed by the classical chisel and hammer. And we have something very special to our area. What you see in the basket, these are not coconuts. These are our Nadan bombs, which are we are very much expert in making, and this also cause all kind of foreign bodies, and usually seen in young males. And the outcome depends on the size of the foreign body, the zone of injury, as well as the complications associated with it. So consequences of IOFB can be immediate consequences, which again can be mechanical, chemical. Mechanical injuries can be the wound, bleeding from that, iris damage, cataract, retinal breaks, retinal detachment, whereas immediate chemical injury can be chalcosis, which is seen with pure copper. Endophthalmitis and inflammation can happen. Secondary complications include mechanical, again glaucoma, PVD, retinal breaks, retinal detachment, PVR. Chemical includes siderosis caused by the iron, chalcosis, again metallosis, and chronic hypertony can happen. So whenever you are faced with a foreign body, always take a careful history. What was the activity? How did it happen? And type and mechanism of injury. So in a rural setting, organic foreign bodies can be seen more common. They result in fungal infections. And time since injury is again very important. And always look for corneal haze, vitritis, etc., which are signs of infection. And if it gets prolonged, there is a higher risk of capsule formation and the foreign body getting hidden. So the examination starts with a careful slit lamp examination. Look for the corneal entry wound. The size of the entry wound will give you an idea what is the size of foreign body that is going to be inside. And always beware of hole side, whether it is a hole in the iris or even a hole in the lid. There was a case where there was a small lid hole and patient had 6/6 vision. So it was not bothered to check the fundus, and patient actually had an intraocular foreign body which had gone through the lid hole. So never even neglect a lid hole. And anterior chamber, you can have the foreign body in the angle. So do a gonioscopy, especially when you have a chronic recurrent uveitis in a patient with a corneal scar. And fundus examination, nothing beats indirect ophthalmoscopy. Do it as early as possible. Get a dilated fundus examination, because soon the cataract will develop. You won't be able to see the foreign body. So nothing like seeing it directly with your eye. But if many cases it is not possible, so B-scan is the most important tool which is needed for localizing a foreign body as well as diagnosing a foreign body. Again, the sensitivity of B scan is much higher than that of CT scan. Even you can pick up small foreign bodies which may be missed even on a CT scan. So it's important the technique. Once you have a suspicion of foreign body, you have to do a careful B scan. Bring the area of attention to the center, so that if it is in the periphery, you might miss a high reflectile particle. Reduce the gain always. So whenever you have a foreign body, it will cause a spike which is more than the scleral spike. So reduce the gain and see whether it is still higher than the scleral spike. Then it will always cast most of the metallic foreign bodies will cast a shadow. So this has to be done. Even this case, the first in the picture here on an apparent B scan, you might have missed a foreign body. Once you reduce the scan, you see that there is a foreign body in the sclera. The double optic nerve sign will give you with the tell away sign here. So you can see that foreign body after reducing the gain. And again, CT scan is very important. Even if I pick up a B scan foreign body, usually do a CT scan, because that's the best form of documenting a foreign body. The next, once you have diagnosed and localized a foreign body, the next part is to plan and timing of surgery. Timing of surgery, it's a little controversial because many people recommend immediate surgery. Both has its own advantages as well as disadvantages. Immediate means you are reducing the risk of endophthalmitis. You are also reducing the risk of PVR. Also, the PVR foreign body does not get encapsulated, and it means a single procedure for the patient. That's along with the primary repair. Whereas planned means you do a primary repair first, then you do a intraocular foreign body removal in a second sitting. So here you have an improved control of inflammation. There is a spontaneous development of PVD, making the VR surgery easier. There is reduced risk of bleeding because inflammation has come down. The corneal edema is less and view of the fundus is better, and you can plan your surgery. So in an emergency surgery, you may not get the instrument that you wanted. So that is very important. And immediate intervention is advised in certain scenarios where you have already a retinal detachment, or if there is an endophthalmitis, you may have to go in early. So the route of removal depends on two things: what is the status of the lens, whether the lens is already damaged or not, and what is the size of the foreign body. If the lens is clear, then you look at the size of the foreign body. Whether it is less than 6 millimeter, then you can remove it still through the pars plana without causing much damage. If it is more than 6 millimeter, even if the lens is clear, it is better to do a lensectomy and remove it through the limbal route. And lens is damaged, then there is no issue. We go ahead with doing through the limbal route. So I'll go through few examples of different types of foreign bodies. Here you have a small foreign body. The lens is injured. The B scan shows the foreign body lying in the vitreous. It's not, so that means it's a very small foreign body. It's a light foreign body. It's not very heavy. So here you have a corneal tear, as well as you have lens injury. So the lens is removed. You can see the PC rent there through which the foreign body has gone inside. So all the cortical matter, everything is cleared very well. First you need a good view of the fundus. So everything has to be cleared first. Then a 25 gauge pars plana approach is done, and vitrectomy is done, and you have to induce a PVD. Many of these cases PVD may not be there. So you can see in the periphery the assistant is depressing, and the foreign body, as soon as it is seen, you don't grab it with your forceps, because you will pull all the vitreous along with it and cause a retinal dialysis. So the foreign body has to be cleared of all the vitreous, and for these small foreign bodies, when they fall back onto retina, usually does not cause any damage. But this is not the case with heavier foreign bodies. They cannot be let to fall to the retina. So here, most of the time I take with a forceps so that there is no slippage. This helps you to, here the foreign body is picked up with a 25 gauge magnet. Then it is brought through the same PC rent through which it has gone inside. It is brought into the AC. And then this is iris claw holding forceps. This is very useful. Other than using a McPherson, you can, this gives a very stable grip of the foreign body. The foreign body is removed without slipping back into the retina. Then the surgery does not end there. You have to clear the vitreous peripheral base, because there is going to be a PVR later, and the endolaser is done to the site of impact, and then a 3-piece IOL is placed. This is another case where you have again a small foreign body with the lens is clear. The earlier case we had the lens was damaged, so this is a small foreign body, so we'll remove it through the pars plana only. We won't disturb the lens. So again a vitrectomy is performed. This is also more or less similar foreign body which is hanging in the vitreous. It is let to fall after vitreous is cleared around it. Then the vitrectomy is completed. Here an additional 4th port is placed, and the other one port is enlarged to introduce the forceps. Through the 4th port, a chandelier illumination is placed. so that you can bimanually remove the foreign body. Magnet is introduced. The advantage of magnet is that it gives you you can manipulate the foreign body without letting it fall back. So here it is picked up with the forceps, then it is aligned to the long axis of that forceps. Because when you directly pick it with the forceps, you have to pick it up on whatever position you get it. You don't have a chance to align it. So when you have a magnet, you align it properly so that it comes out through you want the smallest diameter to come through the sclerotomy. Then the sclerotomies are closed. Again, vitrectomy is completed. Fluid air exchange is done. Endolaser is done to the impact site, and tamponading agent is placed. So here you have a large intraocular foreign body, and the lens is already damaged. So the corneal, you can see the corneal tear which has been primarily repaired. There is a large iris injury here. Iris is traumatized badly. So this corneal tear tells you that this foreign body is going to be large, and all the residual cortex or nucleus, everything is removed. Then the vitrectomy is done. There is as expected, there is a large amount of vitreous hemorrhage. There is some amount of subretinal hemorrhage also at the impact site. Everything is cleared, and the foreign body is PVD is induced. Everything is cleared. And here the foreign body is actually encapsulated. It is inside a capsule, and it's below the plane of retina. There's a retinal tear, and it's impacted in the choroid. From there it is slightly lifted. The capsule is removed. And again, these are foreign bodies which you should remove always through the limbal route, whether lens is there or not. So here again it is brought back, and here I'm using the McPherson, but the iris claw lens forceps would have been ideal, because there is always a risk of corneal damage when you are using McPherson. Whereas iris claw gives a protection against the corneal endothelium for the foreign body. This was a little older video. Nowadays I use only iris claw holding forceps for removing it through the anterior chamber. So it is carefully brought out from the anterior chamber. So that is a foreign body matching the size of exactly the size of the corneal tear. But here in this case, there is a lot of retinal damage that has happened. Sorry. So you have to do clear all those multiple retinal tears are there, which has to be tackled. And most of these cases, it is better to put silicone oil, because otherwise severe PVR develop, and detachment can happen of retina. So this is a large IOFB. Here the lens is clear, but the IOFB is large. So as I told earlier, we will have to sacrifice the lens. So initially vitrectomy is done so that before you have to identify the foreign body. So it is embedded in the inferior retina. It is it is encapsulated. PFCL is placed at the macula, and the lens. Sorry. Sorry about that. So it's in the peripheral vitreous. So it has to be removed after clearing all the peripheral vitreous. Here the assistant has to depress very well. You have to clear everything. It is encapsulated. It is actually incarcerated in the choroid as well as pars plana, part of the ciliary body. So the assistant is depressing. That's a depression. That's amount that you are seeing is a depression by the assistant. Then it is slowly cut into that area. So that's a foreign body. That's again taken with a magnet. From once it is cleared, it should not be let to fall back onto the retina. So it is held firmly with a magnet, then brought to the anterior chamber. The lensectomy has already been done. So it is brought through the limbal route. Here a large limbal incision is made, and the iris claw holding forceps is placed. And gently from the magnet it is transferred to the. So here the advantage of the magnet is, even if you slip, it won't fall back. It will be again caught on the magnet. So that makes it very safe. So again, you have to tackle all the posterior segment problems. There is a multiple retinal tears which has to be lasered, and a tamponading agent has to be placed. So this is all in the syllabus. Then something happens where you see that if you go back here, you can see that on the CT scan, you see a foreign body which is coiled inside the eye. This was actually after a blast injury. The Nadan bomb which I was showing, that was injury after that, and you can see a foreign body which is almost extending the entire length of eyeball from the anterior portion to the till the posterior, almost till the optic nerve. Sorry. So it was a long foreign body, probably a wire foreign body. There was traumatic cataract which was removed. Vitrectomy was done. There was vitreous hemorrhage. We thought that some portion of the foreign body may be seen inside, or the entire foreign body may be inside. But after vitrectomy, it was surprising to see that there was no internal foreign body. It was a clear retina. So we went back to the scleral tear which was repaired and started inspecting the scleral tear area. Can we get any hint of foreign body in that area? In spite of being such a long foreign body, we were not able to find out an extent. We actually even hooked the muscle and explored the sclera completely, but couldn't find the foreign body. Now, as I was depressing that area under the ciliary body epithelium, I could see some metallic shine. I thought probably there is a foreign body there. So it was nudged from depressing from the other side, and it was caught with the forceps, and it was pulled out. To our surprise, it was a very, very long foreign body, and it was entirely in the suprachoroidal space with no portion of the foreign body either on the sclera or inside the eye. So you can see it coming out. There is no end to it. It is still coming. I don't know how these foreign bodies go and lodge themselves in the suprachoroidal space without causing damage. So this also can happen, and as I told earlier, it is very important to avoid falling back of the large intraocular foreign bodies. Go bimanual, use magnet as much as possible, and always have the right instrument. And don't think PFCL is a solution when foreign body falls back. Studies have shown that the velocity inside PFCL as well as saline is the same. So if you have a very large foreign body, the best option is to use silicone oil inside. Do a fluid air exchange, put silicone oil and remove it under silicone oil, because inside silicone oil the velocity is very less, it does not cause damage. So to conclude, foreign bodies are very dicey situations. You have to always suspect them from careful history and look for these small signs which will tell you there is a hidden foreign body inside. Localize them properly using all your modalities of imaging, B scan, CT scan, and have planned the surgery thoroughly, have the proper instrument, correct technique. That will avoid you many medical legal cases and also save the patient some vision. Thank you.
Thank you, sir, for this wonderful and well explained talk. Any comments from the audience? Okay, to conclude, I would like to thank all the speakers for their wonderful and well explained presentation. Thank you.